Hey, hey, hey! Welcome to Conversations with Love. I am your host, Rhonda Love, and welcome to my podcast. Boy, do we have a lot to talk about. So I need you to call a friend and tell them to pull up, tune in, and let's get this conversation started. Hey, hey, hey! Welcome to Conversations with Love. I am your host, Rhonda Love, and welcome to my podcast. And in today's episode, we've got a very, very special young lady here, and I'm so excited. And her name is Jitana Benton Lee. Welcome! Woo-woo!
Thank you for having me here, Rhonda.
And one thing you're going to learn from me, Jitana, as all of my guests, I like to have a little fun because we want to keep it informative, but yet light and also fun and hopefully exciting. Okay, so just roll with the sister, okay?
We'll do.
It's all good. But we have Jitana here today because you and I had a discussion. It's been a minute. I don't even want to talk about it in terms of how long I've been trying to get this thing to go through in terms of the podcast. But we had a discussion on the health disparities in African Americans. And I told you, that was one of the topics that I really wanted to bring forth because it seemed like in so many different situations that as Black folks, we had the hypertension, we had the cancers, in terms of high proportionate, kidney disease, diabetes. It was just like every time you would hear all these things, or I would hear, we were always the ones that were at the top of the list, right? And even births with babies, women having babies, just all kind of things. But with that being said, I want you to share, because I know you come from this nurse educator's background and you're a scientist. You've done research in health equality and social determinants in health. And you are currently, right, the associate professor and director at Northern Kentucky Nursing Interprofessional Research Collaborative. Right?
Yes, I am.
So can you give the audience a little bit more background about yourself and what you do as that kind of all relates in research?
Absolutely. So I am a Kentuckian. I call myself a Kentuckian because I grew up on the border of Kentucky and Tennessee. And so going into nursing was natural for me because I noticed in my community of Black and brown individuals that a lot of people were getting sick. And I saw a lot of amputations due to diabetes and a lot of people having heart attacks. And so I knew that I wanted to go into healthcare to learn more about how to help my population of people because there was a disparity. And even as a 16 and 17-year-old, I noticed that there was a disparity in health. And so I went into nursing with the intent of being able to do health equity. And so health equity is that term where we look at different populations of people to try to determine why one group of people is more susceptible to disease and infection more so than another population of people. So that's kind of the work that I do now. So at the university, I teach students, of course, but I also do research on health equity in rural minorities. So why is it that rural Blacks have more health issues than any other population of people? And so when we look at Kentucky specifically, 54% of Black and African American people in Kentucky are obese or morbidly obese. And that same number kind of hits true with heart disease. So we carry a large burden of the heart disease in the United States. And so the work that I do, it kind of looks at why is this happening? Is this part of our genetic makeup? Is it cultural? What is causing these disparities? So that's the type of work that I do, not only in the state of Kentucky, but I also do this internationally through the United Nations. So I am a liaison with the United Nations, and my focus specifically is on health equity and also how to have just and societies where people that are living in poverty get the same quality health care as other populations.
So, girl, you are like all that.
No.
I mean, no, you really are.
Thank you.
I mean, seriously, you really are all that. And we need this because there was something you mentioned. You said when you were 16 years old or within that age that you realized already the health disparities among us as Black folks.
Absolutely.
And I'm just curious, what point was that? What was it that you saw as a 16-year-old?
I remember this woman who lived down the street from me growing up. And so she had diabetes. And she started with a toe amputation. And then she went back and she had a foot. And then she went back and she had a below knee. And then she went back and she had an above knee. And I didn't understand why this was happening. And so a lot of times when we look at health disparities, it could be things that we're eating, right? Things that we're eating, things that we're exposed to. But I really noticed that it was a lack of knowledge in my communities, that the information that we needed to be able to take care of ourselves was not coming to us. So there was a little bit of a knowledge deficit there, right? And so what can we do to be able to educate our community so that they can better take care of themselves? Also, I notice in the rural communities, a lot of times people will say, well, my doctor said, and my doctor said, but they never question it. They never gain deeper insight. It's like, okay, so now you have diabetes or sugar diabetes, that's what a lot of people called it at home, or sugar or that, but they never understood what caused it. And they thought, well, maybe if I don't eat this cake, that'll help my diabetes, but they don't understand it's carbohydrates. So it could be pasta that breaks down to sugar. So it's all those different things that that kind of combine that makes it where people don't know how to take care of themselves. So it's like you have medical professionals up here with the knowledge, but the people that need to take care of themselves don't have the knowledge or don't even feel empowered to be able to ask about their health and their health conditions to be able to improve themselves.
And you know what? Now, right there, you bring up a really good point. And I think of my dad. He has, he's diabetic. He has chronic kidney disease. He has liver cancer, and now he's on dialysis. So, oftentimes, I'm asking him different questions, or even, let's say, early on, before things even got to this point with all of this. And I would say, well, Dad, what did the doctor say? I don't know. Did you ask him any questions? No, I didn't ask him. Or if my brother, went with him, kind of the same thing. So what I found, particularly in our older population, right, is they trust their doctor. And I kind of want to talk about that because sometimes when you have your doctor or that practitioner, we take, and I won't even say older people, it could be folks our age, right? We take kind of what that doctor says is to be true. And what I've learned in my profession and being in sales is that I have an opportunity to sit and talk to physicians, and I'll be honest, some folks I'm like, ooh, I don't know if I would want them as my physician.
Yeah.
Seriously.
I've experienced it as well, yeah.
Yes, because they are either they don't have the bedside manners, or you could tell that they're not patient enough, or they just automatically say, oh, it's just this, and kind of blow it off. And not really delving, kind of doing a deep dive, let me say that, a deep dive in what's really going on with that person. Now, I can say from a personal thing, I like nurse practitioners and PAs, partly because they do have a little bit more, where they take a little bit more time to really hear you out. Whereas I feel just your MDs, and I'm probably, I know I'm in trouble, but I'm just this is my experience, and I've heard other friends say the same thing, is that they feel more comfortable, right, in having those conversations. But my point for just saying all of that is we don't ask a lot of questions. We kind of take for granted whatever the doctor says, but the thing for us as African Americans or Black folks is sometimes there are things that's called bias. Right?
Absolutely. And so that's where I was going to head.
Yes.
So you kind of gave me a wonderful segue into this conversation. So sometimes it is that we trust our physicians and our physician extenders. So I love my physician partners. But I do know that even with our physician partners and physician extenders, there is bias there. And there is that opportunity that people of color may not get the care that they need. And so that bias may be intentional, okay? Or it may be unknown to them. They're just responding to something that may have happened years ago. But what we know is, and this is it used to be the Institute of Medicine, but now it's the National National Academy of Sciences, Engineering, Mathematics. So they did a study several years ago called The Future of Nursing. In that Future of Nursing report, they determined what we needed to allow nurses to be able to do to improve the health in this country. So we're looking at population health, all populations. Specifically, one of the things that they have pinpointed for many years now, and this is a couple of decades, is that we need to hire healthcare professionals that look like the population that they serve, because they're going to get better health outcomes. Because if you're going to someone who looks like you or has a relationship with you, then you're going to have a better healthcare outcome. So it was really interesting. I saw a young lady that talked about, she was a radiologist, and she determined that other radiologists were diagnosing Black people with these conditions, right? And what she realized, it was the hairstyles. It was the hairstyles that was showing up on their radiologic exams. So her being a person of color, she realized, okay, those were braids, that was underneath the patient, and that's what's showing up in the radiologic exams. So what we know is that if we can get people that look like the population that they're serving, several things are going to happen. They're going to go back into their communities and serve that population, because we know that in Black and brown communities, there's not enough healthcare providers there. There's not enough hospitals. We also know there's not enough pharmacies. And I've worked at a hospital here that we knew that if we didn't give medications to the patients before they left the hospital, then they would not be able to get their medications filled, because if it's a hospital, if it's a pharmacy in an area that may be considered underserved, they may not carry certain medications because of criminal activity, right? And so there's all kinds of bias. So it's not just bias on me as a provider face to face with the patient. It's also the bias of where we put our hospitals, where we put our pharmacies, where we put our healthcare providers, where it's community outreach. So there's a lot of bias there. And so we experience it, right? We feel it. So think about during COVID. So during COVID, we knew that Black and brown populations were not getting the care that they needed. Right. Part of it was because of fear of being experimented on, right? So we have that medical fear there of where we know about the Tuskegee, right? And things that happened at Tuskegee.
Right. And that's funny because there's a book you and I kind of talked about, and it's by a physician, and I actually came across it through LinkedIn, and her name is Uchi Blackstock, and the title of her book is Legacy: A Black Physician Reckons with Racism in Medicine. And I remember, and I'm just being honest, how I came across it was a white physician who talked about how well written it was and the information that it provided, and she was kind of taunting that she felt like it should definitely be presented in medical schools to help all physicians, particularly white physicians, understand how to not have those biases, and then how to work with other people beyond their culture and their race.
So intercultural development.
And I love that. See, you know all these terminologies. Sister girl don't know those terminologies, folks, okay? But that's why I have the experts here. But it's funny because there's a couple of little excerpts from her book, and I will say this. Let me say this. This is not an all end all, but when I listen to her book on tape, because I have an opportunity to drive. I do a lot of driving. So for me, I listen to books more, but I also purchased her book. And the thing that I just thought was interesting, she says there's a myth of objectivity that gets perpetuated, and it starts in medical school. This idea is that because you're a doctor, a scientist, you're objective, you can't be biased, you can't be racist, and you don't have blind spots when it comes to your patients. But the reality is that racism absolutely exists in medicine. It exists throughout history, and it's still hurting and often killing Black Americans because of the biases and the slight racism, because physicians or practitioners or whomever are missing or not diagnosing certain things appropriately. And I do want to say this to my audience. This is not to come across as being picky, because truthfully, sometimes folks will go, oh, everyone wants to just holler racism. It's all, but there are these facts out there. There are things that have been done in the past that kind of definitely demonstrates and shows how the biases and the racism can affect us in terms of our disparity. And it's not just about DNA, right? So I don't know if you have anything you want to kind of add to that. I know that was a lot, but I just thought that was interesting.
We have to think of our health as generational, right? Mm-hmm. And so we carry generational trauma in our DNA. Mm-hmm. And so we're going to experience things because of the trauma that our ancestors have felt. When you think about the healthcare industry, we have always had racism there. And decolonization of that racism is very difficult. It's in the policies, it's in the procedures, it's in the locations of things. Mm-hmm. And so it makes it very, very difficult to overcome. And so when we talk about Black and brown people and the care that they receive, we know that when they go into a healthcare environment, their chances of getting care, quality care, is not the same as their Caucasian counterparts. Mm-hmm. They just don't get the same care. They don't get listened to. There's many stories. There is an article called Silencing of Voices, mm-hmm. and it talks about Black women, how they feel like their voices are silenced when they go to get care, that they have to repeat themselves over and over and over mm-hmm. to get the care. This has shown up in women who have had difficult pregnancies, and they're talking to their doctors over and over and over that, they're still having bleeding throughout their pregnancy. They're having this, and then there's a fatality that happens at the end of it. So our voices are not being heard. So they talk about this silencing of Black voices, and that when we go to get care, and we don't always go, mm-hmm. but when we go to get care, our voices are not being heard. Mm-hmm. Now, a lot of time there's healthcare avoidance from us. Why? Because we've had bad experience. So that goes back to that generational trauma, right? Because mm-hmm. Grandma went into the hospital and Grandma never came back, right? And so mm-hmm. now I fear going into the hospitals. I know many women who say they have to force their husbands to go to the doctor, mm-hmm. that we have to push people to get the care that they receive. Me being a nurse, and my background is trauma and surgical ICU, mm-hmm. When I saw Black patients, sometimes it was at the very end. I was like, if they just came to the doctor earlier, we could have saved them. But I know why there's healthcare avoidance. And sometimes it's because of the racism and the bias that they receive. Sometimes it's because they don't accept the insurance that they have, or maybe because they're under insurance, or maybe they don't have the money to be able to afford it, so they put it off. Mm-hmm. And so healthcare has always been challenged with Black patients because it wasn't built for us specifically. There's a movie that you can watch called The Power to Heal. And you can see parts of it on YouTube. There was a panel discussion, and I was part of that panel discussion where they talked about Medicare and Medicaid, mm-hmm. and how Medicare and Medicaid come to part. And so we wanted to be able to help Black and brown communities, and so Medicaid was how it was initially going to be, introduced, and it didn't happen that way. Mm-hmm. So how they had to work Medicare and Medicaid was to look at the poor, because of the poor whites, and then of course the elderly. Mm-hmm. And so that opened up a window for Black people to be able to get health care in the 60s that they weren't always have access to. And
that's, I'm gonna have to check this Power to Heal movie. Mm-hmm. You said it's on YouTube. You
can see parts of it on YouTube. Yeah.
Oh, okay, gotcha. Mm-hmm. Well, I want to go back to something you were saying about women, like maybe through birthing of a child, and you mentioned, because what I realize is sometimes it's not always about you being a Black woman, or a woman who doesn't have access to medical care, because we could even go back to Beyonce. I'll use some of these famous folks who have money, mm-hmm. okay, or Serena. Remember, she went through like episode of several different things when she had her child, and sometimes it's not even about if you have the money or not, because you could have the money and you still be a part of that health disparity equation, if you will, and so I just find that interesting, that it's not just about the social economics. Mm-hmm. I guess that's what I'm trying to say.
Yeah,
it's just truly what we as African Americans or Black folks experience and go through. The other thing that you brought up that I thought was interesting was about the Tuskegee experiment. Well, I remember, and you may know more about this, but I remember being at a conference with my job, and this was honestly during the DE&I time frame during COVID, and a lot of companies were trying to bring up, and talk about equality, if you will, and particularly in the health industry. Like, for example, in research, when they're doing studies and things of this nature. But they had presented this situation where African American women were used to have surgery to figure out different female situations and problems and what they were going through. And so they would have surgery on these women without any anesthesia.
Yeah. And
I just thought to myself, can you imagine?
I cannot imagine.
And those things were real.
Mm-hmm. It was real, and it's rooted in our histories. It's rooted in her DNA. That's the stories our family tell us. And when you talk about that, that reminds me of the Henrietta Lacks story. Have you heard about Henrietta Lacks?
Yes, and I was just thinking that.
The immortal Henrietta Lacks.
Yes.
Movie, wonderful book to read. And, she was a woman that, she went in, she had some OBG issues. They realized that her cells were immortal, is what they said. They just kind of proliferate. And so they took her cells. They didn't tell her. They didn't communicate it to her family. This has been replicated. This has been going on for decades now. I did notice that last year sometime her family finally settled out of court about it. So those are the experiences we've had as Black people that lead to that healthcare avoidance that I was talking about.
Yes,
right?
Exactly.
And so we've had these negative experiences, and those negative experiences lead to health inequities. That's the reason why sometimes we don't get the care we need, is because we don't show up and we're not present when we need to be. However, what we know the biggest issue is cultural difference or race. And so there was a study a couple of years ago, and I don't know the specific percentage, but there was a high number of physicians that believed Black people didn't have pain.
Yes. Oh, hold up.
Yeah.
Wait a minute.
Right.
I remember, and even in this story, that Dr. Blackstock talks about, there is that mention. She mentions that, and she even had a situation when she had gone to an emergency room, and she later found out that she was diagnosed with appendicitis, and she had one of the nurses, we'll just say one of the nurses, come in and talk to her. But she was asking her more about her sexual, what she was doing. Well, when was the last time you had sex? When was this? Da 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 da. She wasn't trying to find out about where this pain was coming from. So Yes.
So that exists, and so they don't think that we have pain, so we're under medicated, and so we have this severe amount of pain. We do know that the skin cells of Black people is a little bit thicker, but just because it's thicker doesn't mean we don't have nerve endings. We still have the same amount of nerve endings. We experience pain.
Trust me, we experience pain. Oh my goodness!
It's about educating our healthcare providers and our healthcare systems, not just the providers, because the systems kind of control a little bit of what the providers do and they think. So we want to educate the healthcare systems about the care needs of Black and brown people, specifically because they create the policies and the procedures for hospitals and doctors' offices and clinics so that we get the best care. And so we need to be aware of that. Now, to go back to that, some of the research I do is in the Black and brown communities to make it available to people that are not in those communities. We do have allies. We do have accomplices, people that want our communities to have better health. But they may not be Black and brown, so they don't understand all what we call the social determinants of health. So social determinants of health are different things that impact our health. Sometimes we just think what we eat impacts our health, but it's not. It's what we eat, what we drink. It's what schools we go to. Because if we're undereducated, most likely we're going to have poor health, right? If we live in a poor neighborhood, there's most likely a food desert there, and we're not going to have access to quality food. If we lived in an older apartment, the water, the pipes, Think about Flint, Michigan, and the lead that was there. So there's all those components that impact us and our health. So those social determinants of health is what leads to us having some poor health outcomes. And then on top of that, then you compound that with racism in healthcare. So that's why you're seeing greater disparities in our communities. And when I talked about that report, the Future of Nursing report, they talked about this is an issue. This is why we want providers that look like people in their community. And this is why we want all healthcare providers, regardless of what they look like, to have some sort of training that's cultural based so they can interact, right, with people that are different from them. So that goes back to where I was saying before about intercultural development. How do we interact with people that look differently from us, love differently, believe differently? Because that's where the disparities are happening, is within those cultural differences and the bias that exists.
Gotcha. And here's the other thing I'll say too, and we may have to come back for a part 2. I love this. But is that when you were talking about, let me slow down. I was going to ask what would be, to kind of finalize this conversation, what would be the answer? But you kind of gave me that in terms of, and I would say the need for more Black or African American physicians, because I was reading again in this book that the numbers were high at one point, but then there was something that happened historically where they started taking a lot of the African American or the Black colleges from us, and so that's why we only have like Meharry and Morehouse, right? So we only have 2 schools, so you can't have as many African Americans, if you will, or Black physicians present. And I'm not saying they can't go to some of these other colleges, okay, because we're in Kentucky.
Well, they have difficulty getting in. That's the issue.
Okay, got it.
Yeah, they have difficulty getting into the other schools. And it's not just physicians, it's nurses and other allied health professionals. We need to see it across the board because, like I said before, we know that they go back into their communities and provide the best care to those populations. And so the thought is it's not just a Black problem. It's not just an American Indian problem or an African American problem. If you have sickness and disease in one population, you're going to have it in another. It impacts everyone. And so we have to do something differently. So having providers that look like the population they serve is a quick fix. And then we have to empower the people. You have to start taking control of your health. And so I feel like sometimes knowledge is kind of taken and stored somewhere that only the elite can have the knowledge of how to take care of themselves, and we have to get it down to and I don't want to say the smallest person, but the youngest person. They need to know basically how to take care of themselves, when they need to go to the doctor, what things they can take care of at home. And so a lot of education and health outreach is needed, and we don't have it in our in our communities as well as other communities. And so, you can look down the street and in most Black and brown communities, you see a ton of liquor stores that sell a lot of alcohol and cigarettes and vape shops and those kind of things. You don't see a lot of doctors' offices and health food stores and wellness stores. So how do we change the narrative there? How do we change our communities to focus on health? And so that's why I do the work I do, because part of it is getting the knowledge to the people so they can make decisions that greatly impact their health in a positive way. And once you give that knowledge to the people, they're greater empowered, they're going to make better decisions, and they're going to be more compliant with their health and their health care. And
it's funny because really, to me, what you're saying, and correct me if I'm wrong, because again, this is a conversation, but I look at that as social economics.
It is.
Right? So if you're in, and let's keep it open here. It's not just a urban, if you're in an urban area that is surrounded by liquor stores and not necessarily vegetables and fruits, blah, 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 blah. But it's also in a rural area.
It's very much in the rural areas.
Which you may have some Black folks, but you're talking about, so it's really, a part of it still too is about social economics. Because if we're living in an area where you have access to fresh fruits and vegetables, and you're surrounded by being able to access a doctor's office pretty readily and quickly, your health may be a little bit better. Not to still say you can't, as a black person now, I'm saying, still can't have those biases, but it is more of a social economics thing.
It is. And so what I want to say to that, when you look at African Americans and you look at those that are born and raised and live in urban areas, and then you see those in rural areas are much more sicker than those in urban areas. But overall, black people in general have poor health. So you look at it, we all have poor health, but when you look at people in cities that may have more access to those things, their health is better, but it's still on their low end. And so why is that a difference? And that goes back to culture and race.
Yeah. So, I'm here to tell you, I know we have talked a lot has been said. That's why I'm saying, I'm just sitting here thinking I had to pause, because I'm like, we're going to have to pick this up again.
Absolutely.
And, carry it on a little, we'll go a little further, and maybe bring in some other folks or whatever. But thank you, Jitana, for your expertise and your sharing and giving us just a little bit of understanding about what health equality is all about, and the biases and all of that. So again, thank you.
You are welcome.
But to my audience, as I said before, I always want to leave you with a little love note as we wrap up this conversation with love. And the love note for today is just simple. It's fight for your health. Fight for your health. Ask questions, okay? So on that note, we're going to sign out. And until next time, y'all take care. Y'all take care. Ooh, that didn't come out right. Y'all take care, okay? I love it. It's live and live in color. See ya.